Okay, good afternoon, everybody. At the outset, my sincere thanks to Dr. Thatte for this opportunity. So I will be talking on this revitalizing the leads in lead margin keratinization by mucous membrane grafting. So I have nothing to disclose in my financial consideration. So if we look at the normal lead margin anatomy, it has a convex inner border. So both upper lid and lower lid has this convex inner border. Then there is gray line, and then comes this mammalian gland orifices, then mucocutaneous junction, and the lead eye part. So lead margin keratinization is because of loss of mucocutaneous junction barrier. That leads to epidermalization, dyskeratosis involving the mammalian gland orifices, altered lead margin microbiome, and squamous metaplasia of the marginal conjunctival epithelium. So here, because of this mucocutaneous junction barrier is lost. That's why this epidermalization has happened in this tarsal conjunctiva. So the commonest cause of lead margin keratinization is this chronic SJS. In these cases, histologically, lead margin keratinization is because of transition of the epithelium from the stratified squamous non-keratinized epithelium of the tarsal conjunctiva, this tarsal palpebral conjunctiva, to this stratified squamous keratinized epithelium. This is a patient who had brachytherapy locally, and here this is this non-keratinized epithelium, and it got transitioned into this keratinized epithelium, and that is the lead margin keratinization. This is a patient who had this chronic use of antiglaucoma medications, and this is a patient who had this mucous membrane pemphigoid, and that is biopsy-proven. And this is the histological picture where this epidermalization happened in the lead margin along with this mucocutaneous junction and this palpebral conjunctiva. So this chronic SJS, here you can see that is the most common cause. So this happens in which cases? So SJS, if it is not managed in acute stage properly, then this chronic stage will happen. And AMT should be done as soon as possible in acute SJS or 10 within 1 week of the onset, preferably within 72 hours before the fibrinous inflammatory exudates gets consolidated and forms the cicatrix in the conjunctiva or form this in blephron. This is a patient. This patient was one of my friend who is the doctor in medicine, and his teacher who has having this Tuhin syndrome was admitted in Apollo Hospital 10 years ago. So this doctor patient informed me. Then I did this AMT at the bedside. So at 5th day. So because of this lead margin involved, so I did without any microscope. I did this AMT without any glue. I just put it and then put this symblepharon ring. And this is even after 10 years also there is no lead margin keratinization. So any patient with SJS or 10 who has eyelid margin involvement in the acute phase should have AMT. Other signs that which should prompt consideration for AMT is that pseudomembranes and tarsal conjunctival or fornical defects. Because all these they will just cluster together and form this symblepharon. So when we put this AMT, so we should cover all the area, including the lead margin, palpebral conjunctiva, fornical conjunctiva, bulbar conjunctiva, and the corneal surface. So if you look at the pathogenic mechanism of cicatricial ocular surface disorders, the lead margin and lash abnormalities can cause chronic blink-related microtrauma to the ocular surface. This patient had this lead margin keratinization, and when this patient is blinking, so this rough surface will rub over the smooth surface of the cornea, and that leads to microtrauma. So that leads to incomplete blinking or closure of the eye, and there is always some interference of the Bell's neuron. So all these things lead to this unwanted exposure of the ocular surface. Because these patients, whenever they are blinking, they will be having some sort of pain sensation. So they will not close or they will not open the eyes. Or if it is open, then it is mid-open only. So unwanted exposure of the ocular surface leads to persistent ocular surface inflammation and subsequent corneal blindness. So what are the decisions when we go for lead margin keratinization management? So in that cases, we have to go for this grading of the lead margin keratinization, and we have to ask the patient's symptoms, and that is the most important thing. Then we have to consider this corneal damage, surface keratinization, and need for intraocular procedures. What I mean that, suppose these patients, if they have this cataract, and this patient is willing for cataract surgery, then we have to go for lead margin keratinization, that we have to treat that by doing this mucous membrane grafting, and wait for 3 months, and then go for cataract surgery. So for grading this is by this Mayo Pasculi et al. That grading as per the cicatrix mediated lead margin or tarsal pathologies and corneal complications. So grade 1 is this mild, there is this sporadic lid margin keratinization. So you can see that this is sporadic and less than 1/3 of the entire length of the lid margin and with minimal subconjunctival scar. And in these cases, the cornea is clear. So this is grade 1. Grade 2 is this moderate, when the lid margin keratinization is between 1/3 to 1/2 of the entire lid length, and then invading up to 1 millimeter of the tarsal conjunctiva, and then subconjunctival scar is that is there, and that may change the tarsal contour without any cicatricial entropy. And cornea, if it is there is haze, it is located only in the peripheral part, and there is vascularization only less than 3 clock hours. You can see that there is vascularization peripheral. So this is grade 2. Grade 3 means that continuous lid margin keratinization, like in this case. This whole lid is involved, encompassing more than 1/2 of the entire lid length and invaded more than 1 millimeter of the tarsal conjunctiva. So this is the tarsal margin, and then it has that means invaded more than almost 3 millimeter in the tarsal conjunctiva, and prominent subconjunctival scar also that causes cicatricial entropy. In the cornea, there may be central corneal haze or scar or extensive neovascularization with more than 3 continuous clock hours of these neovascularizations, which may reach the central cornea. So these vascularizations, if it is continuous, more than 3 clock hours and reaching to the central cornea. So this is grade 3. So treatment options for lid margin keratinization is bandage contact lens, scleral contact lens, and mucous membrane graft. So bandage, and whenever we are treating these patients, the primary goal is reduction of morbidity and prevent complications. That is the primary goal. And secondary goal is this visual rehabilitation. Whenever these patients, they will come, they will ask that whether after surgery my vision will improve or not. We have to tell the patients that if this complications are reduced, then you may get good vision, but your this morbidity, this pain, disability will be better. The word of caution is that it is advisable to avoid any surgical intervention in a patient with SJS or 10 until or unless it is absolutely necessary. Sometimes you may have some sort of problems after the surgery. So if it is really necessary, then only you go for surgery, otherwise no. However, patients with bilaterally scarred central corneas require and desire visual rehabilitation. So conservative management like that, lubrication, epilation, punctal occlusions may not be sufficient, but sometimes you have to use it. Large diameter contact lenses or special scleral lenses do protect the cornea to a certain extent. Lens fitting can be a problem in eyes with significant symblepharon, and poor compliance in these cicatricial diseases are really a problem. Prosthetic replacement of the ocular surface ecosystem, that is PROS lenses, that is FDA approved, restores visual function, supports healing, and reduces symptoms. But all these are only temporary measures. But the permanent solution is that surgical attempt to improve the surface if the underlying pathological process is controlled. So how much time I have? 12 minutes, no? Okay. So indications for MMG is that recipient eye preparation, that is that you have to first differentiate the SJS sequelae from the chronic stages of MMP. This is a patient who had MMP. You can see this pharyngeal shortening, symblepharon, all these things. Because that if you do these cases with this MMP, this will be disaster. Because these patients, these MMP patients need immunosuppressive, but SJS patients don't need it. We have to go for fluorescence staining to establish that keratopathy is due to LMK, that is lid margin keratinization. So here this is the lid margin keratinization, and we did this surface staining, and this is just touching this cornea, and then upper corneal surface is having some SPK. So this, because of this only this SPK has developed, so we have to go for this lid margin keratinization, and it is the ideal case. We have to go for Sarmas test to assess the wetness of the each eye, and should be more than 5 millimeter at 5 minutes without anesthesia. So if the patient is having good Sarmas test, good wettability, then only we go for lid margin keratinization treatment, that is by MMG. So earlier days that we used to go for this living related this conjunctival autograft or allograft to reconstruct and maintain the ocular surface a healthy conjunctiva when available is the ideal matter for grafting. But a full thickness oral mucous membrane grafting is the simplest graft to use it if the conjunctiva is not available. It is preferred over the split thickness mucosal grafts as it contracts less. Split thickness grafts, that is this very thin and it contracts. But split thickness graft is more preferable from the conservative point of view because of its lesser bulk and pinky appearance. So I am now doing this surgery, I am just showing it. So first we have to this horizontal incision by 15 number blade, is placed at the gray line, and all incisions are superficial with the intention of cleaving the epithelium without damaging the tarsus. There should not be any residual patches of normal or keratinized epithelium on the tarsal conjunctival bed. Otherwise, this graft will have some sort of either this graft will necrose, or if there may be recurrence of this lead margin keratinization. So no patches of residual there means epithelium. And the surgery is carried out under general anesthesia with the endotracheal tube secured in one side, and so as to allow this and get the adequate exposure of the oral mucosa on the other side. So then we have to, after the defect is, that means we have to measure, and then we have to put this submucosal injection to lift the graft. So after the graft is removed, then excess fat is cleared from the stomal surface of the graft with carved Westcott scissors, and then we have to suture it by using 7/0 nylon, 7/0 vehicle sutures. First, you have to put this anchor suture, and then you have to suture
Tuhin,
it.
can you just
That's
sum
another
up
2 minutes.
fast?
And then you just go for interlocking sutures.
Dr. Tuhin, can you just sum up
Okay,
fast?
okay, okay. Just 1 minute. So then this way the lower lid also to be done, and then put this fibrin glue. So this is the appearance, and this is after 3 months, you can see this. So the beneficial effects of MMG is that decrease in conjunctival hyperemia, stabilization of the corneal changes, improvement in corneal staining, decrease in corneal vascularization, reversal of the squamous metaplastic changes. So outcomes, does MMG reduce ocular morbidity and improve vision? Yes. This is the patient who had, that means too much morbidity and vision has improved. So this patient had this keratinization, and then this patient had this new vascularizations, and this is the final picture. This is the patient at the age of 12 years, and this is after 12 years also this patient is maintaining good vision. So ideal timing of lead MMG, if surface keratinization is there, it should be done as soon as possible. Otherwise, you may have this complication like infectious keratitis. And what is the worst conditions that can happen? That you should suture it, and sometimes donor may have some sort of hematoma formations. And who can do lead MMG? Anyone, not only the oculoplasty or corneal surgeons. Beginners should at least assist few cases and do first cases under surgeon somebody's supervision. So to summarize, early aggressive intervention to stabilize the ocular surface. AMT in SJS or 10 should be performed within the first week of symptoms when indicated. All patients discharged from the hospital with a diagnosis of SJS or 10 must be followed by a qualified ophthalmologist, as up to 50% of these patients develop chronic complications of the disorder. All ophthalmologists should learn how to identify various sequelae of the SJS and should have knowledge and skills to perform MMG. And these are my acknowledgements. Thank you for your time.